Plantar fasciitis, orthotics for the itis, or plantar fasciosis, is the degenerative part, which we'll talk about in other videos and kind of discuss more as far as what the etiology is of an itis versus an osis, and really how we should treat plantar fasciitis because of the itis or the osis. But like I said, we'll talk about that in future segments. But today let's talk about orthotics for plantar, let's just call it plantar fasciitis for now, because that's what most people call it. So, in a sense, with orthotics, with plantar fasciitis as a presentation, we're trying to unload the fascia. We're trying to do something biomechanically to prevent that fascia from stretching. Okay, and what that essentially means is that if you're walking and you're doing this, the fascia is right down through here. Fascia goes from the inside part of your heel and goes in 5 little slips right to each toe. It's like this broad band of connective tissue on the bottom of your foot. The more you walk, the more you strain it, the more you don't control your biomechanics, the more likely it is that this fascia can tear. And that's what starts the itis. And the scar tissue, forms to heal the injured tissue. Depending on how the scar tissue forms and heals, determines whether it's a functional scar or a non-functional scar. And that brings in the whole osis debate, being a degenerative problem. Osis is degeneration of tissue. So, but regardless of that, whether it's an itis or an osis, we still treat it the same way with orthotics. We're trying to take some of the strain off the fascia. So if you're walking and this is bowing down, you can see I'm stressing that fascia. Fascia is connected from here down to there. So I'm making it bow. So I need something that's going to hold it up over here. Okay, that's number one. Number two, from behind we can actually make a post to try to rotate that heel out to the side to, in a sense, do the same thing. The research is a little bit vague, not too specific, whether this actually does do a lot for the fascia or whether it doesn't. But in a lot of cases we attempt it and it does well for people. Some people do just a neutral heel where it's nice and flat, and we get just as good a result. Okay, what research does tell us, and this is counterintuitive to some things that some podiatrists do and some therapists do, is that we post the orthotic, meaning we keep the orthotic thicker on the outside, and then we skive it and wean it down so it's thinner towards the big toe. Okay, what a lot of therapists do is they load it in the opposite direction. They have a flat foot that's rolling in, so they really try to build this up so it's higher here than over here. For plantar fasciitis, that's not the best thing to do because research tells us that by having this higher than the outside, it actually loads the fascia more and causes more pain. So if your orthotic is thicker here, because of the way your therapist or your orthotist or podiatrist made it, that's not the best way to treat plantar fasciitis based upon the evidence that's out there. Okay, so it's just the opposite. We're trying to, in a sense, keep this higher over here and keep the big toe lower relative to it. Okay, we call that a valgus post or a lateral post versus a medial post or varus post is something that does more like this, keeps the big toe higher. Okay, so that's the mechanics of how we would treat it. So if you look at the orthotics that we make, let's talk about the first thing we talked about, this whole idea. Okay, you got the foot on the orthotic. We're trying to hug that orthotic up to the mid part of the foot to the navicular, so the navicular bone doesn't drop. Okay, with this one, we actually did angle it about 5 degrees in the back for somebody who's overpronated, who's flat-footed. And then what we do in the front, this is going to be a little bit tougher to see, okay, is that we keep this lower relative to this over here. I don't know if you can see that on the bottom here, but if I flip this over, you can see what I've done here. So I've kept it thick over here, and I've skived it and thinned it down through here. Okay, so if you really think about this from a biomechanical standpoint, I guess really almost a common sense standpoint, if you pick this side up, okay, pick this side up and let the first metatarsal go down, it's almost like you're slackening the tissue. Okay, the whole idea of this kind of dropping, the big toe drop beneath the level of the platform that I'm on here, it actually in a sense brings this metatarsal head closer to the heel. Versus if we do just the opposite and raise this up higher, so this whole foot raises up, and we do a post this way, it's almost like you're stretching that fascia a little bit more. Okay, but like I said, the evidence definitely plays out to the fact that the post that we did here takes the pressure off that fascia. Okay, and that's work that was done by Kogler and his group. So, and then as far as another option, you can actually go with more of a neutral heel over here. Okay, and then what I did over here, just as another option, you can actually do a post between 2 and 5. So some people have like an issue with their first metatarsal joint. Okay, degeneration or a spur or whatever, it just hurts. Okay, so what I do is I keep this a little bit thicker. You see that?
Yep.
Okay, a little bit thicker here relative to there. So I'm still, you know, keeping that big toe lower than the second toe, but I'm just not doing as much of that valgus post that I did with the other one. Okay. And then lastly, some people do fine without anything fancy, and they want something that's softer against the heel. So we go with the softer material, P-cell. That's a lighter durometer foam that's softer. Go with a middle layer of poron, which is a material that doesn't bottom out. It never thins down. And then go with a nice heel pad. And inside here, what I do is I grind down the top cover that I mold to the foot, and put another layer of this stuff so they're really soft through here. And then same thing, hug it up against the midfoot, and not much, none of the posting that we did in the other two over there. So, of course, what I do is dictated by what the patients tried before, what kind of shoes they have, how sensitive their feet are, how much they weigh, how sedentary or active they are. So there's a lot of things that factor into this. But this at least gives you a couple options for what I do in the clinic. So, and that's it for orthotics for plantar fasciitis. Thanks.